On understanding psychological assessment and social emotional disabilities, presented by the Recruitment, Training, and Support Center at the Federation for Children with Special Needs. My name is Janie Greco, and I am the Training and Support Specialist at our PSC. Our IT people this evening are John Sullivan and Emily Gaudet. If you are interested in learning more about the Federation, please go to our website at www.fcsn.org and explore all the different programs and training opportunities that we have. Our presenter this evening, Dr. Joseph Moldover, is a graduate of the Institute for Graduate Clinical Psychology at Widener University, where he completed dual concentrations in neuropsychology and cognitive behavioral therapy. He served in clinical research at the University of Pennsylvania School of Medicine and completed a postdoctoral fellowship in pediatric neuropsychology at the Children's Evaluation Center in Newton. In his independent practice, Dr. Moldover's interests include evaluation and management of children and adolescents with learning disorders, developmental disorders, neurological injuries, and psychiatric disabilities. And we are doing a simulcast with a webinar this evening, so just so everyone knows, on the webinar, the PowerPoint was emailed to everyone last night, so if you don't have it, you should check your inbox. It's being recorded so that those who cannot attend can retrieve it on our website at a later date. If you have any questions, please type them into the toolbox, and I will present them to Dr. Moldover when time allows. That's for the people on the webinar. Please note that the last 30 minutes of the seminar will be a question and answer time. For those online, we will make every effort to make the audience questions audible to everyone. Their bathroom is down the hall. You go out this door, take a right. You have to come around and come back in the main door. There's snacks in the back, and Dr. Moldover's book is available for sale for $10. Okay? So welcome, Dr. Moldover.
Thanks. Okay, guys, well, thanks for coming, and thank you all at home for tuning in, or I guess whatever you call it when you do this. You know, one drum that I've kind of been beating for many years is the importance for psychologists to explain what we do to people who are not psychologists, to teachers and to advocates and to parents. And to be sort of less obtuse and less jargony and more transparent. So I'm especially happy to be here tonight talking to all of you. And yeah, the book is available here at the front. The proceeds from it go to the Federation, so it's to a good cause as opposed to me, which would be a questionable cause. And yeah, tonight we're going to be tackling psychological assessment and social and emotional disabilities. It's a really big topic. So I'm going to try not to skip over anything important. There are probably a number of things within this that could be talks in and of themselves. So I'm going to try to cover all of the bases that I can. And then during the question and answer, if there's a particular topic that you're really burning to hear about, please, please bring it up because there's a lot here. To begin just with an overview of kind of the prevalence and the scope of what we're talking about, we think that approximately 20 to 25% of children in this country have a diagnosable mental disorder or addiction. So that's a tremendous number. That's 1 in 4 to 1 in 5 kids. Now obviously it's sort of difficult to establish those numbers with certainty, and as with anything else, there's a really wide range of severity. So just because somebody has a diagnosable problem doesn't necessarily mean that it's something that's really disabling. Somebody could have, a phobia or something like that that might be diagnosable, but might not be a huge day-to-day problem in their lives if they, avoid spiders or whatever it might be. But we think that of that number, about 10% of kids suffer from a mental disorder that's severe enough to really cause significant functional impairment in their day-to-day lives. And so that's still a very large number. And it's they're underserved, they're under-identified, and they're underserved. So NAMI, which is the National Alliance for the Mentally Ill, estimates that about only 20% of children in need of mental health service wind up being identified and helped. So we have the majority of these kids really flying under the radar out there. Now, within sort of the context of special education, of kids in this country receiving special ed services, about 7% are identified with an emotional disorder. That doesn't mean that the other 93% don't have mental health issues. It's just that these are the 7% for whom that's the primary disability on the IEP. Okay? IDEA has a very broad definition of what they call emotional disturbance. If you look at sort of the bullet points on this slide, you see how sort of broad it is. You know, an inability to learn that cannot be explained by intellectual, sensory, or health factors. You know, very general. A general pervasive mood of unhappiness or depression. Inappropriate types of behavior or feelings under normal circumstances. It's very general. It does specify that it includes schizophrenia. It specifies also that it's not something that's transient, that it's something that occurs over a long period of time. So what IDEA is trying to specify is that we're not talking about a very temporary, short-term emotional disturbance. This is something that persists over a long period of time. And also that it's something to a marked degree, that it crosses a threshold in terms of becoming a disabling condition, something that's really impacting a child's day-to-day life. And if you look at the bottom bullet point, it also specifies that the term does not apply to children who are, and this is the words of the law, socially maladjusted, unless it's determined that they have an emotional disturbance. The Commonwealth, Mass DOE, in regard to what it calls emotional impairment, sort of elaborates that a little bit, saying that the determination of disability shall not be made solely because the child's behavior violates the school discipline code, because the student is involved with a state court or social service agency, because the student is socially maladjusted, unless the team determines the student has a serious emotional disturbance. In other words, it's not just about the behavior. It's not just about a child who's demonstrating problematic, atypical behaviors. There needs to be an underlying emotional disorder, an underlying, what we can call a mental health issue, mental illness. So it's not just the behavior, it's the underlying disability. So, when we talk about this stuff, there are a number of issues with it that are, with these types of situations that are particular challenges for advocates and for teachers and for other caregivers. When you look at these types of disabilities relative to other types of disabilities. One of them is that the team tends to be a little bit different. So, I think many of us, if we are working with kids with learning disabilities, working with kids with autism spectrum disorders, the professionals who work with kids with those diagnoses become very used to dealing with the special education system. Speech-language pathologists, neuropsychologists, and so forth, and become very used to the terminology and the procedures and just the regulations of the special education system. The team tends to be a little bit different when you're dealing with a child with a primary emotional impairment. You're more commonly dealing with mental health professionals, obviously, with psychiatrists, with counselors, psychotherapists, social workers, and so forth. People who may not in their day-to-day life be interfacing with the educational system as regularly and may not be as familiar with it. So that's one challenge. Related to that, you're trying to get two different systems to interface with each other. You're trying to get the healthcare and the educational systems to sync, which is very, very challenging. These are two systems that tend to have their own jargon, their own terminology, their own procedures. And, one thing that I've oftentimes felt when I've been working with kids who are diagnosed with, mood disorder or some other psychiatric disorder is that I sometimes feel like they're falling into the cracks between the educational and the mental health or the clinical systems. And so trying to kind of get these two systems to talk to each other and to communicate with each other and to try to get seamless transfer back and forth between the two is a huge challenge. If you're an advocate, if you're teaching kids with these diagnoses, if you're a parent of a child with this sort of a diagnosis. And the third thing is that I think that oftentimes when you're talking about these situations, there is still stigma when we're talking about mental health issues. You know, I think that there's been tremendous progress over the last generation when we're talking about diagnoses like autism, learning disabilities, cognitive disabilities, in terms of destigmatizing these diagnoses and bringing them out into the open. I think mental health issues, oftentimes we still feel uncomfortable talking about these things when they occur in our children. It can be especially sensitive to talk about these issues when they're associated with trauma, which is one thing that we're going to be talking about tonight. So oftentimes that's an additional barrier to advocating and supporting these kids. And there's another complication that I also want to talk about. And it's, in some ways it's ironic that we're having this talk on April 30th because in May 2013, a new book comes out. It's the DSM-5. So I think many of you probably know what the DSM is. Some of you may not. Some of you listening may not. But the DSM is the Diagnostic and Statistical Manual of Mental Disorder. It's a big, big book that's put out by the American Psychiatric Association, basically defining hundreds of different mental illnesses and providing criteria for hundreds of different mental illnesses. And new editions are issued periodically. We've had the DSM-4 since 1994. They did what's called a text revision, which was a minor revision. But this is the DSM-5, which has been in the works for many years and has caused a great deal of controversy, and it's finally being published next month. So this is going to really change the face of mental health terminology and mental health diagnosis in a number of different ways. And if we're dealing with kids with these diagnoses, we really sort of have to stay current with this, and that's an additional challenge. I don't want to say I'm going to say a bit about DSM as we're going along. I don't want to say too much about it now. One point that I do want to make about it is just to be clear about what it is and what it isn't. I think that people kind of tend to look at the DSM as this sort of, Bible of mental health, where, if it's not in the DSM, then it's not, then it's not real, or something like that. The purpose of the DSM is really just to have consistency in terminology. Okay, the problem that the DSM set out to solve originally was that there was really no consistency in what mental health professionals meant by different diagnoses. So, one person might talk about depression and another person might talk about depression, and they might mean totally different things. If one person was a Freudian psychoanalyst, they might have one idea about what depression was. And if somebody else was a behaviorist, they might have a totally different idea. And so without that consistency, there was really no way to move mental health science forward. If everybody's talking about different things using the same terms or talking about the same thing using different terms. So the purpose of the DSM was just to get uniformity in language. And that's really it. It's, it's basically a big dictionary. It says exactly what do we mean when we say depression. What do we mean when we say autism? What do we mean when we say bipolar disorder? Now, it's become something more. It really has become very important in terms of funding services, in terms of eligibility for services, in terms of health insurance coverage. So what's in and it's not in the DSM does have real practical importance in people's lives. But just because something's not in the DSM doesn't mean that it's not real. Most of you probably know that the DSM-5 is going to talk about autism spectrum disorder and is not going to include a diagnosis of Asperger's disorder anymore. That doesn't mean that Asperger's suddenly winks out of existence at midnight tonight. It's just that it's not defined, it's not codified in this particular book. Nonverbal learning disability has never been in the DSM, and it's still not. That doesn't mean that it's not real. Okay? Some of the other changes in the DSM, besides ASD, which I think probably many of you are familiar with, and it's been an ongoing debate and discussion for quite some time now, it's going to be introducing something we're going to talk about tonight, which is disruptive mood dysregulation disorder. It's going to be introducing some other diagnoses like a hoarding disorder. It's going to be expanding the diagnosis of post-traumatic stress disorder. So there are going to be a number of different changes that are going to be in DSM-5. So it's not that everything I'm going to say to you tonight is going to become obsolete, but the terminology is very much in flux at this point. So with all of that being said, my goals for just speaking to you tonight are to give you an overview of the important emotional disorders, or not that the other disorders aren't important, but some of the most common ones: depression, bipolar, anxiety. I want to talk about trauma. I know that complex trauma is one particular topic of interest. I want to talk about that a little bit. And I want to talk about assessment, and I want to talk about management within the context of education. Okay, so that's basically what we're going to try to tackle here. So I'm just going to begin just by talking about depression, okay? And what I have up on the screen are the current DSM, DSM-4 criteria for depression. I won't go through and read them all to you, but the main point is that it's not just about mood. When we use depression in a colloquial sense, we are sort of using it as a synonym for feeling sad, right? And the actual syndrome of clinical depression is much more complicated and more severe than that. It includes depressed mood, but it also includes behavioral changes, changes in weight and appetite, sleep patterns, energy levels, alterations in thought processes, feelings of guilt, feelings of worthlessness, inability to concentrate. It's really a multifaceted syndrome. It also involves not just depressed mood, but the loss of positive mood, the loss of interest in things that were previously interesting, loss of pleasure in things that used to be pleasurable. We're going to come back to this when we talk about kids and depression, because this is an important point for kids who have a difficult time reporting what they feel. Especially if we think about, for example, kids on the autism spectrum who may have a difficult time really being able to put into words what it is that they're feeling. This shift in terms of interests is important. A child with Asperger's syndrome, for example, who might derive a great deal of pleasure from some particular unique interest, like let's say ski maps or something like that, who suddenly loses interest in that and isn't finding pleasure in that anymore, that can be a sign of depression. Okay, it's not just the sadness, it's that loss of pleasure and that loss of interest, what's called anhedonia. There's a continuum of disorders when we talk about depression, running from what we call adjustment disorders, people who are having symptoms of depression in a reaction to some sort of a life stressor, to dysthymia, which is basically a chronic, low-level depression, to what's called major depression, which is the full-blown depressive syndrome. And, it used to be thought that kids didn't get depressed. And not that long ago, there was real debate in mental health about whether children could develop depression, which sort of sounds silly to us now, but people really seriously thought that kids were not cognitively sophisticated enough to really develop depression the way that adults do. And, we now know that that's nonsense. And depression itself is one of the more common mental illnesses. 20% of people over the course of their lifetime will experience clinical depression. The average age of onset is age 14 to 15. Okay, so not only do we see it in kids and adolescents, but for most people who suffer from depression, the onset is before age 18. At any given time, the prevalence rate in kids is 1 to 2%, in adolescents is 3 to 8%, and it's much more common in females. The female-to-male ratio is 3 to 1. All right. As I said, we know much more than we used to about depression in kids. It can be identified reliably in children as young as age 3. There are many different causes of depression. As I said, the DSM is basically a terminological resource. It doesn't talk about why somebody has depression. All right? It says nothing about cause. It says nothing about the recommended treatment. It's just a list of criteria for what depression is, for what the term means. you can think of it, and you can think of many of the things we're going to talk about, as sort of a place with many different roads leading to it. There are many different pathways to depression. Some of them may be entirely biological. They may be entirely rooted in a child's neurochemistry and their metabolism and have really nothing to do with their environment. For other kids and adolescents, it could be entirely environmental. It could be completely a reaction to some sort of a loss or some sort of a stressor. All right? So it's a very heterogeneous group. If you put a bunch of kids with depression in a room, you'd see a lot of different pictures and have a lot of different stories. We think that generally speaking, in these very young kids, it's more likely to really be driven by biological factors. And conversely, in cases where it first appears in later childhood and adolescence, which as I said is more typical onset, it's more likely to be a blend of both biological factors and environmental causes. We think that for most people it's a combination. There's probably some sort of a biological or a genetic vulnerability, and then there's some sort of an environmental stress which may trigger it. Okay. Probably the most important point to make about kids and adolescents with depression is that they tend to look different than adults with depression. As adults, we tend to really internalize our feelings of depression, right? We turn them inward. So we feel sad, we feel worthless, we have low self-esteem, we get into bed with a big jug of ice cream and just burrow and shut down. Kids are much more likely to externalize their unhappiness, to externalize their depression, and to turn it outward. And so oftentimes it comes out in terms of irritability and anger and aggression. A lot of kids who are referred because of, quote, oppositional defiant disorder, oppositional defiant problems, are actually kids who are depressed, kids who are acting out feelings of depression, kids who are on a hair trigger because of depression, have a very high level of frustration and agitation. And so oftentimes for kids with depression, what brings them into the office or into the clinic is not that they're saying, I'm sad, I feel badly about myself, the types of things that you or I might say. It's more that they're acting out, that they've become impossible to live with, that everybody's walking on eggshells around them because they're going off at the drop of a hat and they're irritable. And they're acting out in school, again, sort of, quote, with oppositional defiant behavior. So that's probably the single most important point to appreciate about these kids, is how the behavior can mask the depression. And that if we're not careful, we can miss the depression. And we can wind up treating them as kids with behavior problems and using disciplinary techniques that are probably going to make the depression worse. Now, another point to make is that the irritability or sadness, when you see sadness, are not specific to depression, okay? You see lots of kids with irritability. Kids with anxiety are irritable. You see irritability and low frustration tolerance and all sorts of kids with developmental issues with ADHD, with lots of different diagnoses. So kids with depression have those symptoms, but so do tons and tons and tons of other kids. So the question is, how do we kind of narrow it down? What do we look for in young kids who may have depression? And I mentioned the top one before, this quality of anhedonia, loss of pleasure, okay? Lack of pleasure, lack of positive response, lack of interest in things that had previously been reinforcing, that had previously been positive, all right? Excessive guilt, really inappropriate, difficult to understand guilt. Extreme fatigue. And, especially important when thinking about these kids in school, reduced cognitive skills, that you see a decline in terms of attention and concentration. You can see slower information processing. You can see reduced executive functioning in terms of planning and organization and things like that. So, you can see some of these cognitive symptoms of depression even in a child who's not overtly saying, I'm unhappy, I'm depressed, I don't feel good. Yeah, please.
When you have someone depressed in a child, kind of be situational, like, or would it be overall all the time? You know, you see kids that they, when they're doing something that is interesting to them, they may not have some of the symptoms that you're talking about, but when they're not interested, they do have some of these symptoms.
Yeah, so let me just repeat that for the web audience, okay? So the question is, do we see depression that is situational and that's sort of present in some contexts and not present in others? Generally speaking, when we're talking about real clinical depression, it's something that's going to be present sort of across times and across environments. You do see symptoms of depression oftentimes in kids, for example, with learning disabilities, who might show a lot of those symptoms when they're at school and when they're doing their homework. But if you look at them on a Saturday morning or during the summertime, you don't see those symptoms. Typically, we wouldn't necessarily talk about that as a child with clinical depression. We talk about that as a child who's having an adjustment problem with school because of their learning disability. It doesn't mean that it's not severe, that it's not something that we're worried about. It just means that it's just a little bit of sort of a different flavor of a mood problem. Yeah. Okay, so I've been talking about depression. Depression is a type of a mood disorder. Another way of talking about it is to call it unipolar depression. And so I'm going to open up a big can of worms by talking about bipolar depression. And if the existence of depression in kids was controversial at one point, bipolar depression in kids remains really intensely controversial. And it has been for over a decade now. When we talk about bipolar disorder in general, what we're talking about is still a mood disorder, but one in which periods of depression alternate with manic episodes. This is what used to be called manic depression. And on the slide, I have what DSM-4 lays out as symptoms of a manic episode, symptoms of mania. It specifies that this is something which is lasting at least 1 week unless hospitalization is necessary, and that to a significant degree we have a lot of these symptoms that in some ways you can think of as almost the opposite of depression. So somebody with depression might have feelings of negative self-worth, worthlessness, I'm no good, those types of thoughts. Somebody with mania may have increased self-esteem, may have what's called grandiosity. I'm the best. I'm better than all of you. I can do anything. Those types of thoughts. Somebody with depression might sleep a good deal of the time. Somebody in a manic episode might go for days without sleeping and have decreased need for sleep. Somebody with depression may move slowly, speak slowly, think slowly. Somebody in a manic state may be more talkative than usual. Oftentimes their speech has a very distinctive pressured quality where it's almost like the words just can't come out fast enough. They may be very distractible. Oftentimes you see an increase in goal-directed activity, that these are people who decide, okay, I'm going to stay up for 24 hours straight and clean my entire house from top to bottom, or paint my house, or write a novel, or buy a piano and learn to play, even though I've never played before. Okay, these types of behaviors. It's when you see really a frankly manic episode, especially in an adult, it's very clear. There's really not much mistaking it. When I used to work in adult inpatient psychiatric settings, it was very, very clear and non-controversial when we saw this sort of thing come in. Now, the question is, how common is this in kids? And what does it look like when it happens in kids? Again, as with depression, there was a period of time when it was thought not to exist in children. People thought that bipolar disorder had its onset in later adolescence, young adulthood. It's fairly well established now that it does happen in children, but there's immense controversy around exactly what it looks like and how often it happens. One study of depressed adolescents, for example, found that 20 to 40% went on to develop a form of bipolar disorder, which seems very high. But if you look at the statistic underneath that, we know the diagnosis of bipolar in children has increased 4,000% since 2001, which is incredible. And I think that seems about right to me. In 2000, 2001, I was working in a inpatient psychiatric setting in Wilmington, Delaware, at what used to be Wilmington General, and we had a child unit, and one of the child psychiatrists started talking about childhood bipolar, and that he thought that some of these kids had bipolar disorder, and that he wanted to start to treat them with the mood stabilizers that are used for adults with bipolar disorder. And it was this very novel idea. People thought that he was kind of nuts. He was kind of on the cutting edge. This was in 2000 now. And yeah, and since 2001, we've seen this explosion. And in some ways, it is sort of reminiscent of the discussion and the debate around the diagnosis of autism spectrum disorders, which many of us are probably familiar with. That there's this tremendous growth in the diagnosis of autism. And what is that all about? Is autism occurring more frequently? Are people overdiagnosing autism? Is our definition of autism changing so that more people meet the criteria? It's a very similar debate around childhood bipolar, okay? But that's sort of the magnitude of it, 4,000%. And a lot of the debate hinges around whether we use what we'd think of as a broad or a narrow definition of what bipolar looks like in youth. And essentially, there's a school of thought which says that in kids, symptoms that are sort of classically manic, especially the grandiosity, sometimes are replaced by not just irritability, but rage and aggression. And so if you use sort of very strict criteria for bipolar disorder, you probably don't find as many kids who really meet that criteria. If, on the other hand, you say, look, it doesn't always look like what DSM talks about. In kids, sometimes what we see is the anger and the rage and the aggression instead of the grandiosity and the euphoria. Then all of a sudden we have a much, much, much broader definition. And this is probably what opens the door to sort of, a 4,000% increase in diagnosis. So the question is severe, non-episodic irritability an early manifestation of mania? That is the basic question that psychiatry has sort of wrestled with for over a decade. And the way that DSM-5 is dealing with this is by creating a new diagnosis, which is oftentimes the way DSM deals with things. We are going to have, as of next month, a diagnosis of disruptive mood dysregulation disorder. And many of you have probably heard about this. This has been in the media a good deal, along with the autism changes. It involves rage is out of proportion to the situation with chronic negativity and irritability, but without clear mania. Okay, so these are sort of the broad definition kids. These are kind of the specific criteria that I most recently saw were going to be in DSM-5. Intense, disproportionate physical outbursts and or verbal rages at least 3 times weekly. Persistent, irritable, angry mood between episodes, and defined as occurring between ages 6 and 18 with onset before age 10. So this has caused a lot of concern. I think that people on the one hand are concerned that there's a lot of overlap between this diagnosis and normal child development, normal child behavior. People have sort of parodied this in terms of talking about pathologizing temper tantrums. And so, one concern is that, we're taking kids who are intense, who have tantrums, who may be having tantrums, intense tantrums for environmental reasons. Perhaps their parents need support, perhaps their schools need support in working with them, and we're labeling them with a major mood disorder that may lead to medication with heavy-duty mood stabilizing or antipsychotic medication that can have significant side effects. So that is one, very real concern. Another concern is that there's a lot of overlap between this diagnosis and diagnoses that we already have. The slide says bipolar versus ADHD, but under bipolar I sort of include this DMDD diagnosis, okay? there's a lot of overlap. How do you tell the difference between these kids and kids with ADHD? They share a lot of symptoms: distractibility, overtalkativeness, restlessness, disinhibition, inappropriate social responses. Some of these sort of very classic symptoms of mania can set them apart. As I said, when you see the elation, you see people going for days without sleep, you see the grandiosity, you see hypersexuality. These are things that really stand out and tell you, okay, we're clearly dealing with a bipolar disorder. That's not ADHD. That's not something else. But a lot of these kids don't have those cardinal symptoms. How do you tell the difference between DMDD and ADHD? Kids who are impulsive and maybe frustrated. So this is another issue. And in general, what we're concerned about is over-pathologizing kids and over-treating kids, especially with what can be very heavy-duty medications. All right? The last point that I just want to make about mood disorder, and I sort of already made this point, but what I want to emphasize is that mood disorder is not just about mood. Okay, it's not just about feeling sad. It's not just about feeling depressed. And for our purposes, in terms of thinking about kids in school, it's especially important to emphasize that it involves cognitive problems. It can involve impairment around learning and memory, around attention, processing speed, executive functioning. Many of you know that executive functioning and attention are dependent on frontal systems in the brain, the frontal lobes of the brain. And there's evidence that especially in people with bipolar disorder, that there may be actual structural atypicalities in terms of the way that the frontal lobes are put together. So these kids oftentimes don't just have difficulties with mood, don't just have difficulties with behavior. They also have difficulties with learning, and we'll try to come back and talk about that a little bit. The other point to make, and I've been referencing these medications, right? I've been talking about kids with bipolar syndrome as being placed on very, on medications that can have really significant side effect profiles. Oftentimes, these medications, like mood stabilizers, can have a real impact on how quickly a child can process information and on their working memory capacity, how much information they can process at one time. So oftentimes we use these medications, and they may, I'm not trying to slam these medications, they save some people's lives, but we use these medications and we may be able to successfully control some problems, but they may then cause others. They may then cause some cognitive problems and some learning problems. So I could say a lot more about mood disorders, but I'm sort of trying to watch the clock and stay on schedule, and I want to move on and talk a little bit about anxiety as well. And I know that a lot of people want to talk about trauma, so I want to make sure that I leave enough time for that. So if people have more questions about mood, we can come back and talk about that later during the Q&A. But I want to shift gears and talk a little bit about anxiety. Anxiety is one of the most common forms of mental illness in kids and adolescents, with prevalence of 10 to 20%. When we think about anxiety, I think we see a problem that we see more than we see with mood, which is where do you draw the line between normal anxiety and clinical anxiety? Okay? When you see clinical depression, especially as I was saying, bipolar disorder, it's a real slap in the face. You really know it when you see it. Anxiety, I think there are oftentimes many more shades of gray. And that's because anxiety is something that we all have. We all have to have. People evolved to experience anxiety. Our ancestors who didn't have anxiety, who weren't wired to be anxious, did a lot of stupid things. They marched right up to saber-toothed tigers, and they jumped off of high cliffs, and they generally did not live to pass along their genes. And so anxiety is something which is good. It keeps us safe. It's adaptive. The way that I'll sometimes talk about it when I'm explaining it to a kid in particular is that it's like the smoke detector in your house. Okay? You want to have a smoke detector in your house. You want to have something that gets your attention if there's a problem. The problem with anxiety disorders is that it's kind of like the smoke detector starts going off all the time. And so not only is it no longer useful to you, because you don't know when there's really a fire and when there's not, but it's also a huge headache and a huge problem in your life. So, anxiety disorder, most anxiety disorders we can differentiate from normal anxiety on the basis of interference with functioning. that when somebody starts to have anxiety that limits them, that keeps them from doing things, keeps them from going certain places, and from having normal life experiences, then we're sort of crossing the line into a clinically significant problem. All right? You know, I might not like to fly. That might be something that I'm uncomfortable with. When do I cross the line into having a flying phobia? Probably when I can't get on the plane, when it's something that limits me from being able to do things in my life that I want to do. So, you know, there's one issue here in terms of what is the actual functional impact, how limiting is it? And then the common anxiety disorders can be then differentiated from each other based on the focus of the anxiety. Separation anxiety obviously centers around separation from the caregiver. Social anxiety on entering into social situations. Phobias, as I just said, are specific to particular scenarios. Flying, snakes, spiders, public speaking. You know, a lot of these different types of things. Thankfully, I don't have. Generalized anxiety disorder, a diagnosis for kids who, as the name implies, have generalized anxiety that cuts across situations and settings. There are other less common anxiety disorders that have more distinctive patterns. OCD is one, obsessive compulsive disorder. OCD is a very interesting disorder. That's something that, again, I would love to have more time just to talk about OCD. You know, as many of you know, it's defined by a combination of obsessions, of repetitive, intrusive thoughts, oftentimes about topics such as cleanliness and safety and things like that, and then compulsions, which are behaviors that are done to address the obsession. So I might have an obsessive thought that, oh my gosh, maybe I left the stove on at my house. All right, well, that's intrusive. It keeps on popping into my head. I can't stop thinking about it. It's driving me nuts. All right, well, my compulsion is I'm going to call my wife and just ask her to check the stove and make sure it's turned off. Okay, she says it's off. Okay, great. Start to move on with my day. 5 minutes later, did she really check? Is it possible the stove is on? You know, sometimes it looks like it's off, but it's just a tiny bit off on the dial. I'm just going to call again and have her actually go over and check the stove. So it's that dance of the obsession, the compulsion to alleviate the obsession, the return of the obsession, and so forth. Question, yeah. Yeah, so the question is, can it just be the obsession without the compulsion? I'm just repeating it for the web audience, as I did hear you. Going to be the obsession without the compulsion, as in the case of kids with spectrum disorders who do things in a very repetitive sort of a way. That's not really considered to be OCD. You know, kids with spectrum disorders who are very fixed in the routines that they need to go through, or the way that things need to be done, and get very upset if there's a departure from that, what we'd call a real need for sameness, can really resemble OCD, but it's not quite the same as what we mean by OCD. In the case of OCD, it's a very sort of distinctive flavor of these thoughts that come into my mind that I experience as being intrusive. So in the example that I gave, I know the stove isn't on. Like, I'm a rational person. I get that. I know that even if it was on, it wouldn't matter. The house wouldn't burn down. And yet I just can't get rid of that obsession. It's like flypaper out of my hand. I just can't quite put it down. And so I have to do this thing to address it that temporarily gives me relief. A kid on the spectrum probably isn't going to have quite that attitude. They're not probably going to say, oh, look, I know that we don't really have to drive to school that way, but I just really want to. No, they really expect you to drive to school in that route. And there's not that sort of insight. So it's sort of a different flavor. Yeah, thanks. Probably the main point I want to make about OCD for our purposes is that, as with bipolar, there's a clear role of frontal brain structures in OCD. Oftentimes these kids have problems with processing speed and executive functioning. There's a very high co-occurrence with frontal lobe syndromes that impair learning, especially ADD and ADHD. Also Tourette's syndrome. Pandas, so the question is, what about pandas? PANDAS is pediatric autoimmune neuropsychiatric disorder after strep infection. How do you like that? I can just say that. That's a special interest of mine. So the question is, it's a little bit of a controversial diagnosis. The idea is that certain kids, after strep infection, develop an autoimmune reaction where parts of the brain, especially frontal lobe, what are called frontal lobe subcortical structures, are attacked by the immune system, and that produces symptoms of OCD. So it would be considered to be a subtype of OCD. It's very controversial. Typically, primary care doctors, pediatricians, oftentimes don't believe in PANDAS. Psychiatrists and neurologists are more likely to view it as valid. I view it as valid. I do think that there is a subtype of kids with OCD where the OCD symptomatology does seem to be associated with strep infection, and oftentimes these are kids who get better when they're put on long-term antibiotic therapy. There is a infectious disease specialist at MGH who does a lot of work in this area. You can ask me his name, and it's going to leave my head, but it'll probably pop back in before I leave for tonight. Okay. But yes, that is so. PANDAS is sort of a medical subtype of OCD. Yeah. Yes. Probably not. Pediatric. Yeah. Sorry. Thank you. Pediatric, autoimmune, neuropsychiatric disorder after strep. Sure. Yeah.
So I'm curious about kind of how you have these factors arranged, because I know there seems to be a trend lately with schools and with certain mental health professionals to attribute slow processing speeds and poor working memory to anxiety, even though they show up on the neuropsychological profile. The child has anxiety and has this profile. I see people want to attribute one thing to the other.
Okay, so the question, tell me if I get this right, I'm just going to repeat it for the microphone. So the question is that, the issue is that sometimes clinicians in schools seem to frame slow processing speed and limited working memory capacity as the result of anxiety, and is that sort of valid, or does that make sense? Is that sort of the question? Okay. Yeah, I think that that's oftentimes a mistake. I mean, I think that oftentimes what we're seeing is that the processing issues and the anxiety are the product of a third variable. So they're sort of different sides of the same coin. That you see these kids with these frontal lobe syndromes, like OCD, where the brain abnormality gives rise to those cognitive problems and also to the anxiety. And if we say, well, the kid just sort of bombed the processing speed and working memory subtests on the WISP because of anxiety, then sort of what follows from that, then we may not give them help around those processing issues and say, okay, well, if we put them on Zoloft and address the anxiety, they're going to process more efficiently. That may be the case. That may be the case for some kids, but I think a lot of these kids, in fact, are going to be anxious as long as they're being overwhelmed by the pace and the volume of instruction. And if we don't give them instructional supports around the processing issues, we can give them as much Zoloft as we want, and they're not necessarily going to get over the anxiety. That makes sense. Okay. I'm not going to spend a lot of time on panic disorder and agoraphobia. That's a much less common condition in kids. And PTSD is something that we're going to go into more detail about in 2 slides, so I'm not going to talk about it here. But again, kind of echoing what I said around depression, it's important to emphasize that anxiety disorder, is not only about the emotion. It's not just an emotional disorder. There are emotional and physiological aspects of it: fear, this feeling of hyperarousal, of being keyed up, that fight or flight response where your heart beats more quickly and your palms are sweaty and so forth. Physical complaints, okay, headaches, GI problems, but also behavioral issues. One key aspect of anxiety is avoidance. In many ways, anxiety is all about avoidance. Avoiding the feared situation, avoiding the feared stimulus. That I have the spider phobia, I don't go near the spider. I'm afraid of flying, I never go on a plane. OCD in many ways. The compulsion is about avoiding the obsession. I can't deal with this obsession, this intrusive thought that my stove may be on. So the compulsion is to quiet it, to make it go away. I'm avoiding the obsessive thought. So in a lot of ways, a very good way of thinking about anxiety and anxious behavior is that it is essentially avoidant. And it's cognitive, okay? It's intrusive, persistent worry, and it is hypervigilance. It eats up cognitive resources. People who are anxious have fewer resources left for other things. For kids, that means they have fewer mental resources left for learning and for doing work. In my OCD example, I'm spending time thinking about my stove. That's mental resources that aren't allocated for different things. We're going to talk about kids with trauma being hypervigilant for threat. But people with anxiety are scanning their environment for threat. And that is mental resource that can't go into learning and can't go into performing in school. Now, I know that one topic that people really do want to spend time on is trauma, so I want to jump to that. Again, in the Q&A, I'm happy to come back and circle back to OCD or anything else with anxiety. OCD and pandas are a special interest of mine, and so I can go on about it all night, so feel free to bring that back up. But I do want to talk about trauma. I just one resource I just wanted to make sure that I put up on the screen is that Mass Advocates for Children has been working on this issue for a number of years in collaboration with Harvard Law and the Task Force for Children Affected by Domestic Violence. They have a publication called Helping Traumatized Children Learn. The website for the publication is on the slide. So it's a great resource. Yeah, it's hard to see, I guess, in the blue. Sorry, it should be on the handout. If you go to the Mass Advocates website, you can get to it. So I'm going to touch on some of these things, but they have a very, very long publication you can download. It has a lot on understanding and supporting traumatized children, on interventions in schools and so forth, and that's a great resource, so I just wanted to make sure that I put that out there. Okay, so when we are talking about trauma, one important distinction that we need to make is between what we might call simple trauma and complex trauma. Calling trauma simple isn't to say that it's mild, but it's to say that it is a discrete, shocking, overwhelming event within the context of otherwise normal development, leading to post-traumatic symptoms, which I'll talk about. I mean, unfortunately, in this area, we've all seen that over the course of the last month, right? I mean, we've all seen that with the marathon bombing. This was a shocking, overwhelming event, especially for people who were present for it. Any of us can experience a simple trauma. What it essentially is a sudden departure from the script. You think that you can walk down the street safely, or that you are safe in your home, or that you can drive on the Mass Pike without being worried about, accidents, or that you can go to watch the marathon and not be concerned about safety. And then there is some sort of a dramatic, overwhelming, terrifying departure from that script. It breaks your assumptions and it breaks your expectations. That can be a car accident, that can be an assault, that can be obviously something like the bombing, and it can happen to anyone. Now, complex trauma is something which is different. Complex trauma is an ongoing trauma forcing a fundamental adaptation in terms of defense mechanism and personality. What does that mean? What I'm basically saying is that it's not so much something that breaks from the script, it's something that actually changes how the script is written. It is a chronic, ongoing, traumatic experience that fundamentally alters the way that a child thinks and learns and grows. Okay, it's not one discrete event. And this can be different things. We can see this in kids who have lived in war zones, for example. But probably the most common source of complex trauma is interpersonal victimization in the home, child abuse, or domestic violence that the child may not be the target of but is witness to. All right, interpersonal victimization and violence in the home. Does that distinction sort of seem clear between sort of the simple and the complex traumas? So these children who experience child abuse and neglect are at high risk not only for psychopathology, not only for emotional disorder, post-traumatic stress, and depression, but also they're at tremendous risk educationally. They're more likely to have below average academic skills. They're much more likely, multiple times more likely to have to be retained, to repeat a grade, and they're much more likely to require special education support for academics. One point that oh, sorry, yeah, question, yeah, sorry. Yeah, the question is what do we mean by interpersonal victimization, and it doesn't necessarily refer to physical violence. I should have skipped by this bullet point on this slide. What I wrote is that it's particularly toxic when a child can't experience a sense of security and consistency with caregivers. What I basically mean by that is, certainly that would include situations in which violence, physical violence, is being done to a child, or in which a child is witness to physical violence between others in the home. But it would also be more broad and would include verbal and emotional abuse, as well as neglect, as well as the absence of caregiving. Yeah. Thanks. Yeah, please. Yeah.
When there is developmental delay or other vulnerabilities in the child, does that broaden what would consist of what would create trauma, either complex or simple? What would define trauma?
Yeah. So the question is, when a child has developmental delays, would that broaden the definition of what would define trauma? Yeah, that's a great question. I'm not sure that I have a pithy answer to that. What I would say is that, in general, there's a lot of debate in the trauma field about what is and is not trauma. Do you have to be physically present to be traumatized? Okay, can you have been traumatized by the marathon bombing even if you weren't physically present there, if you experienced it, on TV and on social media? I think the short answer here is that sort of trauma is in the eye of the beholder, and it depends on your experience of it. If you experience it as something that is overwhelming and threatening and unpredictable, then it is much more likely to be traumatic for you. And so, I think we can say that a child with developmental challenges, a child with developmental delays, on one hand may be more likely to be overwhelmed than a child who has more resources for coping with the situation. So yes, there's not just sort of one definition of, this is a traumatic experience, this is not a traumatic experience. There are soldiers who go through the same experiences in war. One gets severe PTSD and the other doesn't. Okay, there's not a one-to-one relationship between the trauma and the disorder. So I think what I'm sort of saying in a roundabout way is I think that the answer is yes. And I think that probably in some ways having developmental delays does make a child more vulnerable to traumatization. Would be sort of my short answer, yeah. I want to talk, I'm going to point out in a moment that not all children who have problems with trauma have what we would sort of classically consider to be PTSD. But I do just want to sort of touch on what are the symptoms, the typical symptoms of PTSD. This is going to be revised somewhat in DSM-5, okay, so this is not written in stone. But these are sort of the classic clusters of post-traumatic symptoms, all right? One of them is the hypervigilance and the hyperarousal, the constant monitoring, the constant preparing for threat. I alluded to that earlier. Okay, the resources that go into scanning the environment, preparing. You know, if I'm somebody who was assaulted on the street, you know, I'm walking down the street, totally keyed up now, in a fight or flight response, scanning all over the place, aware of everybody in my environment, monitoring everybody for whether they look like they might be a threat, that type of hyperarousal, hypervigilance. The re-experiencing. Okay, this is what we sometimes think about when we think about people with PTSD. The trauma coming back recurrently in an unwanted way. Nightmares about the trauma, flashbacks to the trauma, or just sort of persistent, repetitive thoughts that you can't get out of your head about the trauma. And then the third piece, avoidance, behavioral avoidance. Yeah, you know, I was assaulted. I was assaulted on the street. I'm not going to walk down that street anymore. I'm not going to go into that town anymore. I'm not going to go out at night anymore. I'm not going to walk on the street unless I have somebody with me. Okay, avoiding the situations that remind you of the trauma. Cognitive avoidance. I'm not going to think about it. It's oftentimes very difficult to get people, especially kids, to talk about trauma. There's a real tendency to try to avoid those thoughts and feelings. And then the numbing, the emotional piece. A sort of a protective emotional numbing so as not to feel the emotional effects of the trauma. So those are the three sort of classic clusters of symptoms that we generally think of when we think about sort of PTSD. Now, children who experience complex trauma, where it's not a discrete event, it's not just sort of one traumatic, awful thing that happens, it's an ongoing traumatic experience and environment, they may not have that presentation. They may not meet criteria for PTSD. There's a term, developmental trauma disorder, that it's sometimes used to characterize these kids, but they may not have the DSM diagnosis of PTSD. But it's nonetheless a severe problem. And you know, one thing that we're sort of coming to appreciate about it is that it's something which, as I said before, can really fundamentally alter the way that a child's brain develops, their social development, their ways of dealing with stress, that it can, as I said, it doesn't just break from the script, it rewrites the script, or it writes the script in a certain way. It changes who a child is, it changes their personality. And it can change their brain. We are learning that, that chronic exposure to trauma in both children and adults can change brain structures, and that one part of the brain that may be especially sensitive to overexposure to stress hormones is the hippocampus, which is a part of the brain that's critical for new learning. And we know that in adults with trauma, for example, veterans with PTSD, we can see on imaging, we can see the hippocampus actually it changes in its structure. We can see these people having problems with memory and learning. We know less about the impact in children. But the point is that trauma is not just psychological, trauma is physiological. Having stress hormones circulating in your blood at very high levels chronically is not good for you. It's not good for your heart, and it's not good for your brain. And it can change the structure of the brain. Yeah. Yeah, the question is there hope that with rehabilitation the brain will continue to change? Yeah, thanks. That's a good question. The answer is yes. I mean, there is some research that when trauma is treated and stress level declines, you can see some reversal in some of those neurological changes. Yeah, thanks. Okay. Manifestations of complex childhood trauma. What's going on with these kids, especially through the lens of learning? You know, one very interesting thing about the development of kids with chronic trauma or complex trauma, and this is something that the Mass Advocates book it gives a lot of information about, is that it's associated with language disorder. That growing up in an environment that is overwhelming and unpredictable seems to make it difficult for children to learn how to think sequentially and to learn how to express themselves verbally and to learn how to create a verbal narrative. And that a lot of these kids seem to have real difficulties in both expressive and receptive aspects of language, and especially around what we call narrative comprehension and construction. So not necessarily the very basic building blocks of language, not necessarily the very basic issues that we might see in a child with autism in terms of sentence structure and pronouns and sort of the very basic building blocks. Oftentimes these kids will have those fundamentals. It's that they can't use those building blocks to build a house. They can't sort of put it together to create a coherent narrative or understand a coherent narrative. And in some ways you can kind of understand that because they've grown up in an environment that is unpredictable and where things oftentimes don't make sense. And A does not necessarily follow from B, and C doesn't follow, and so forth. And so they sort of have a difficult time being able to think in this sort of integrated, organized sort of a way. And you can see that in terms of real delays in terms of language development. And we'll come back and talk about that a little bit when we talk about treatment. Also, these can be kids who are vulnerable to social and emotional misinterpretation. I'm going to skip by that for the moment because I'm going to come back to it later when I talk about testing. And these are kids who can have deficits in attention and self-regulation. Growing up in an environment that's overwhelming and unpredictable makes it very difficult to learn how to self-regulate, how to control your emotions, how to control your level of arousal. So, trauma disorders and ADHD may coexist. You can have both. But oftentimes we might see the dysregulation and just call it ADHD and not necessarily appreciate that it may have a traumatic origin. So in other words, the self-regulatory problems that we might call ADHD might be due to trauma. Deficits in executive functioning. You know, if somebody is growing up in an environment where there's constant threat and where, you know, they don't know what's going to be happening down the road, they're just dealing with the immediate environment. How do I deal with the threat that's in front of me right now? How do I get through this moment? How do I get through this evening? How do I get through this dinner? How do I get through this encounter with this person? These are not kids who are really being trained to think in the long term or to engage in big picture thinking. They're growing up with a sense of a foreshortened future. They're not thinking about getting the project done in 2 weeks. They're thinking about surviving today. And so these are oftentimes kids who are not going to develop good planning skills or good skills around organization. And these are oftentimes kids who will demonstrate challenging and oppositional behavior. As I said, they're prone to social misinterpretation. If they're kids who are used to people treating them unfairly, who are used to people treating them aggressively, they're going to be more likely to interpret the behavior of another child, the behavior of a teacher, in that light, and to react. Oftentimes these are kids who have a need for control as a defense against anxiety. They may find it unbearable to not be in control because when other people take control in the past, they've gotten hurt. And so they may have a very difficult time relinquishing control to the teacher in the classroom, and they may be tagged with, oppositional behavior, or termed as having oppositional behavior. And they may be people who have identified with the aggressor. One thing that we've known about kids with trauma for a very long time is that a very basic defense mechanism for feeling like a victim and for feeling helpless is to identify with the person who's doing the victimization and to become like him or like her. And so you oftentimes will see these kids actually enacting their trauma in other settings, in school, by being aggressive or inappropriate or whatever the case may be. So oftentimes, as in the case with kids with depression, oftentimes these are kids who come to our attention because people are concerned about and complaining about their behavior, their oppositional defiance. And in fact, once you kind of look under the hood and dig into the situation, you see that what's underlying it is trauma and is this vulnerability and anxiety. We're going to start to hurt for time, so I'm not going to spend a lot of time on this slide, actually. This is a little bit of a different perspective on trauma. It says, this is a quote from a set of researchers on child trauma: not an impaired brain, but a unique brain, actively adapted to survive in a malevolent social world. I think that there's a useful school of thought on child trauma that sort of looks at kids with complex trauma as not necessarily showing cognitive deficits, but as people who are adapted to a certain horrible environment, and that they are bringing those adaptations with them into school. So, when you see some of these behaviors, then I was just talking about some of them, identification with the aggressor and so forth. When you see some of these behaviors that seem so atypical, seem so difficult to understand, you can sometimes ask yourself, why and where would this type of behavior make sense? Under what circumstances would this make sense? And oftentimes you're sort of thinking your way back into the environment that child is coming from. So we don't really have time, I guess, to really sort of delve into that as much as I might like, but it's just a little bit of a different perspective in terms of thinking about traumatic disorders. That in some ways it's not so much a disorder, it's an adaptation to a disordered environment. Okay, so let me see. Yes?
I have a question from someone in the audience that is interesting. She's asking what the difference is between RAD, which is reactive attachment disorder, and PTSD.
Okay, so the question is, what is the difference between a reactive attachment disorder and PTSD? A reactive attachment disorder is a behavioral syndrome that we see for kids who have disrupted attachments with caregivers, and oftentimes their behavior can resemble that of kids with PTSD. Oftentimes you can see disorganized, aggressive behaviors. Oftentimes you can see impairments around language and executive functioning, so that's a good point. That is a diagnostic group that would probably resemble these kids. And in a lot of ways, you can think about that rupture in attachment with a caregiver as a trauma. There's not much that's more traumatic for a child than to lose or to not have a source of attachment. And so I think the answer is that there's a lot of overlap there.
RAD is still in DSM-5, right?
Is RAD in DSM-5? I believe so. Yes, I believe so. You can go to the American Psychiatric Association website. They do have a handout about changes in DSM-5. You can also wait a few weeks and buy it at Barnes & Noble, but I believe it is still in there, yeah. Okay. So let's see. So in terms of a time check, I know we started a few minutes late, but if we want to have time for Q&A, I should probably stop talking in about 15 minutes. Is that about right? Okay. So let me just try to zoom through a couple of things, and then we'll transition over into Q&A, okay? I wanted to make a couple of points just about social emotional disabilities in developmental disorders, okay? We've been sort of talking about depression, anxiety, trauma in kids who are sort of otherwise typically developing, and we had one question about trauma in kids with developmental challenges. I just want to make a couple of points. Intellectual disability may result from, obviously it can result from many, many different causes, okay? Some of them, especially fetal alcohol exposure, which is a very common source of intellectual disability, may be associated with very significant emotional and behavioral problems. So oftentimes when we see kids with intellectual disabilities, depending on the origin of it, even though that may be the primary diagnosis, oftentimes it's the emotional disorder that may be in some ways more problematic and more functionally limiting. I said earlier that we've got 7% of kids on IEPs coded with emotional disability. There are lots of kids who have other disability codings who also have very significant emotional and behavioral problems. And again, it's not unusual for that to be a bigger problem for the family, a bigger problem for the school than the cognitive deficits per se. PDD. There is, I think as most people know, there's increased prevalence of depression and anxiety among kids and adults with autism and Asperger's. It can be very difficult to tease them apart. Okay, I referred earlier to this sort of hypothetical child with Asperger's who loses interest in what had been their fixation, who suddenly isn't enjoying ski maps, whatever they had given them pleasure before. The point with this is I have these symptoms of depression that I had shown you guys before. Next to it, I've got common manifestations of PDD. Difficulty in establishing and maintaining relationships, lack of spontaneous seeking to share enjoyment, lack of social and emotional reciprocity, restricted interests, challenges in attention and executive functioning. A lot of overlap with symptoms of depression, and as a result, it can be very easy to miss the depression in kids with PDD, okay? And that's, especially the case because oftentimes these are kids and adolescents and adults who have a very difficult time talking about and identifying and communicating their feelings. Some of you might remember the term alexithymia. Okay, this is an old psychiatric term. So it comes from a, lack of, lexi, word as in lexicon, thymia, which is feeling or mood, as in dysthymia for sadness. Lack of words for feelings. People who are not able to put their feelings into words and express themselves. It used to be a much more commonly used term. The reason that it's not used that broadly anymore is that we figured out that a lot of these are people with Asperger's. And so the word Asperger's is now used for many of the people who would have once upon a time had that label from a psychologist or a psychiatrist. But apart from being of historic interest, that I mentioned that because that is a real aspect of the syndrome for many people who have it. This difficulty in being able to really emotionally introspect and identify and talk about their feelings. And again, it can make it very, very easy to miss the depression. But I think that we know that there's a very high level of depression among folks with spectrum disorders, and that it's very important to treat it. I mean, we think especially about teenagers who are dealing with the social world of adolescence and transition to adulthood while coping with symptoms of Asperger's, high-functioning autism, and so forth. So, okay, so I want to be able, oh gee, I'm really going to run out of time. Okay, I'm just going to skim through this really quickly. So this is just sort of a summary that, these disorders are not only about emotion and behavior, they're also about learning. They involve social skills with deficits, behaviors, inconsistent academic engagement, problems in information processing. I'm not going to belabor any of those points. I want to carve out just a few minutes to be able to talk about assessment and intervention before we turn things over to Q&A. Okay, so let me just jump into this and try to deal with some of this stuff. So assessment, psychological assessment around emotional and psychological issues. Historically, we've divided these types of tests, these types of assessments, into two categories, objective and projective assessments. When we talk about objective assessments, we are oftentimes talking about things like questionnaires. things where the individual might fill out a questionnaire, their parents or their teachers might fill out a questionnaire, and we would statistically compare what somebody says about themselves or what they rate about themselves with a sample of other 14-year-old boys. What a teacher observes about a child, what a parent observes about a child, with parent and teacher observations of other 8-year-old girls. Okay, that's why we call it objective, because there is sort of an objective statistical comparison of observations and of self-report with a sample, with a quote normal sample. Okay, just like with an IQ test, we would look at somebody's performance doing a puzzle or defining vocabulary words and compare that with a normative sample. One of the criticisms of this type of assessment is that it is vulnerable to manipulation. Okay, it's only as good as the observations and the self-report that go into it. If you give me a depression inventory and I don't want you to know that I'm depressed for whatever reason, and I just check off 0 for every item, guess what? I've got a score in the non-depressed range. If you ask me to fill out a questionnaire about my kid, and I am going nuts with my kid at home, I am just at my wit's end, and I want help. I want my kid to be on an IEP, I need home behavioral services, I need insurance to cover psychotherapy, etc., I can check off very frequently for every item on the questionnaire, and it's going to blow things through the roof in terms of the results of the questionnaire. Okay, so you know, what the tests yield is only as good as what goes into them. Now, the main point that I want to make is that many of these tests are more sophisticated than that. And one question that we want to ask when we use objective measures is whether they include validity indices. Whether the test tells us something about not only what the individual is saying, but also how they are saying it. So many of the more sophisticated tests, both self-reports and parent and teacher questionnaires, are sensitive to things like exaggeration. They have items included within them that are really not true, even for kids with severe mental illness. And so when people start to check those off, it's a red flag that there's exaggeration and manipulation going on. They have indices of minimization. Okay, one of my favorite anxiety questionnaires for kids and adolescents has items embedded throughout it that sound sort of like, I never make mistakes. I am always polite to everyone. I always have good manners. When kids start to check off those items, those are the kids with anxiety. Okay, those are the kids who have this sort of perfectionistic, rigid way of looking at themselves. So even though they may deny all of the symptoms of anxiety on the questionnaire, we know that they're anxious because they've endorsed a lot of items on that perfectionism index. There are indices of random responding. Okay, there are items embedded throughout the questionnaire that should correlate with each other, and when they don't, I know that the 17-year-old who I was testing really didn't want to be there, really wanted to go home, and just made pretty patterns with the dots on the sheet, and is totally invalid. So the good objective assessments, the more sophisticated objective assessments, tell you something about the consistency and the transparency and the level of exaggeration or cry for help that's present in how somebody responds to the questionnaire. All right, and that's something that you want to look for. Now, beyond these objective assessment instruments, we also have what's called projective assessments, or projectives. And projectives are something that, again, could be sort of a whole talk in and of themselves. Generally, when we talk about projection, what we're talking about is a defense mechanism where I mistake what is interior for exterior, where there's something that I'm feeling or thinking that I feel really uncomfortable with, so I essentially reject it and instead mentally place it out in the environment. I'm feeling really mad, and for whatever reason, I'm somebody who's really uncomfortable with that. I'm somebody who really feels like it's not acceptable for me to be mad. So maybe, you know, I repress that, I don't admit it to myself, I don't act mad. Maybe I don't feel mad. But, maybe, you brush up against me in the hallway when we're walking down the hall. God, why are you so mad at me? Why are you so aggressive? I'm projecting it onto somebody else. I'm mistaking this feeling as being out there when it's actually in here. I mean, that's the concept of projection. And the idea of projective testing is that you sort of capture that with a test. And the most famous projective test is the Rorschach ink blot test, which has been around for almost 100 years now, and was given to us by the original Dr. Rorschach, who was a Swiss psychiatrist, and has been used in a lot of different ways and oftentimes misused. And I guess I would make sort of two quick points about this, okay? First of all, the idea of the Rorschach ink blot test is that I show you a set of 10 ink blots, one at a time, and ask you what it looks like to you, okay? They're all symmetrical ink blots. Half of them are color, half of them are black and white. They're always the same. There's one standard set of ink blots. Just for the record, it's unethical for a psychologist to show the ink blots. I know you see them sort of like hung up as art. I think they were on Jon Stewart a week ago. Yeah, right. Maybe it was really, Jon Stewart's not a licensed psychologist. He can't lose his license for that. But if I gave him an ink blot, I'd be in trouble. Okay, that's supposed to be protected material. But what I ask you is, what does it look like to you? Whoops. Am I doing that, or I don't know if I did that or something else. Okay. Thanks. And I ask you what it looks like to you and what makes it look like that. Okay, is it the shape, is it the color, is it the shading, whatever, okay? Now, there are sort of two different ways that I could interpret your responses, okay? I mean, I could just sort of do a content interpretation. Oh, you see a lot of animals in the ink blots. So I'm going to infer from that, based on, my theoretical presuppositions, that there is something about your personality, that you are somebody with a lot of repressed emotions, whatever. That type of interpretation is nonsense. And that probably says more about the psychologist doing the interpretation than it does about you as the test taker. And you shouldn't look at that type of interpretation as valid if that's offered for your client or your child, your student, and so forth. There is a much more legitimate way to approach interpreting the ink blot test, the Rorschach test. And there is a standardized system of Rorschach interpretation that was developed by the psychologist John Exner. It's called the Exner system. And it's actually sort of turning the Rorschach into an objective test. You score the person's responses in a very quantitative way. How many responses did you offer? How many were based on color? How many were, et cetera, et cetera. And you compare it to a normative sample. Okay? I'm not going to say tons and tons about that, except that we have to be super, super careful about using that system, using that technique with kids and adolescents with developmental and learning and language differences. Okay? That system was developed for working with kids with psychiatric disorders and trying to understand, is a child depressed or are they not depressed? And so forth. A child with Asperger's syndrome can generate a very atypical Rorschach profile. I've seen kids with Asperger's who were diagnosed with psychosis based on their Rorschach responses. Why? Well, I mean, maybe they produced a very, very, very statistically atypical number of responses about insects. Well, guess what? Maybe insects are their special interest. Okay? You see kids with nonverbal learning disability generating very atypical Rorschach responses and sometimes looking psychotic. They have visual processing problems. They do see things differently than other people. People with language-based learning disabilities. This is a language test. I mean, you look at the blob, but then you have to be able to convey to the examiner what it looks like and why, using words. So, for many, many, many of the kids that we see who have learning disabilities, language disabilities, spectrum disorders, NLD, all these different things, it can really lead you astray. And so you're sort of getting my perspective. You're stuck with me tonight. Other psychologists would probably tell you something different. I personally don't use the Rorschach in my practice. I've seen it do, frankly, more harm than good in the kids that I work with. I do think that there's probably a role for it in certain populations with very trained examiners using a system like the Exner system, but I think that that is a very small sliver of the uses of the test, and that it has real potential to lead us astray. Okay. There are other projective techniques. There's what's called apperception tests. Okay, the most famous is the thematic apperception test. I show you sort of ambiguous pictures and ask you to tell a story about the picture. Drawings, I ask you to draw a person, draw a house. Sentences, I give you a sentence stem. At school, I like to blank, and you fill in the blank. All of these are sort of different projective techniques. They're sort of premised on the same underlying idea. All of them have the same problem, which is that they can sometimes tell you more about the examiner, what the examiner believes, what the examiner wants to conclude, than they do about the kid. In cases where the projective tests are very, very, very telling, the kid draws a house and it's on fire, something like that, oftentimes that's not the only indication that this is a kid with anger. Oftentimes, there's a lot of other signs, without needing to do that, that this is a kid who's dealing with anger issues. So, I think oftentimes the information that it gives you that's useful, you can get other ways and easier ways, and the information that it gives you that's more obscure is more unreliable. So that's, but that, again, I mean, that's the world according to Moldover. Other people will tell you different things. I can't move on. Stuck on the slide for the moment. Call tech support. Thanks. Okay. A couple of other quick things about assessment. I mentioned, going back to the trauma issue, kids who do have complex trauma should have speech and language assessment or assessment of language with a neuropsychologist. Okay, again, these are oftentimes kids with receptive and expressive language challenges. Again, oftentimes they can do the lower level language stuff. They can do syntax. They have good vocabulary. You give them the SELF, the clinical evaluation of language fundamentals. They can do okay. You really have to look at the higher level language functioning, at their ability to really functionally use language at the level of narrative sometimes to see the challenges. Academic achievement testing. All of these kids, whether we're talking about kids with trauma, kids with depression, whatever, they are all vulnerable to academic skill deficits, academic skill delays. They all need to have academic achievement testing to make sure that they're not falling behind in terms of their academic skills. And many of them, as we were discussing earlier, also have neuropsychological challenges, especially around attention and executive functioning. And we were saying earlier that it's not necessarily the case that the reason these kids are bombing a test of working memory is because they get jittery when I start asking them to repeat digit strings. Oftentimes the working memory delay and the emotional issue are both originating from the same underlying neurological factor. So neglecting those cognitive problems sometimes really shortchanges these kids on the academic and the cognitive supports that they need. And again, if you have a child in a learning environment where they feel overwhelmed and they can't keep up, it's very, very difficult to get a handle on their anxiety or their depression just by using medication and counseling. The assessment process is not just testing. You are thinking about your observations of the child, behavior during instruction, behavior during unstructured social times of the day. I had one child who came into my office, and there's a shelf above the table where we sit to do testing, and there's a jar on the shelf. And this child, we sat down to start working, and he seemed really distracted. And finally he said, can you just move that jar? I'm really, really worried that that jar is going to fall on my head. Nobody had there's no way the jar could fall on your head, for one thing. And most people don't even notice the jar. And nobody had ever interpreted it that way as a threat. A perfect example of somebody who's putting cognitive resources into scanning the environment for threat and then interpreting something that 99% of us would not interpret as threatening as a potential source of danger. Okay? And, that kid sort of felt comfortable enough to ask me to move it. And out of curiosity, so I moved it, and then he came back to the office, and I put it back to see if he would notice it again, and he did. I mean, he was always scanning, trying to be safe. This wasn't a kid who we had a lot of test data around anxiety. The evidence for his anxiety was really more in terms of those types of observations. So it's not always something that you see on a questionnaire or that you see on testing. Oftentimes it's observations like that. Across time, across settings, we talked earlier about kids who are depressed in school, but they are like a totally different kid on Saturday morning. Okay? Gives you a real clue about the source of anxiety, the source of depression. What about kids with trauma who are very uncomfortable with men, but do very well with a female examiner? Okay? Some of these variations in a child's emotional state across people, time, settings are really important clues as to what's going on with them emotionally. And last but not least, in terms of helping these kids, we think about a lot of different things. In terms of accommodations, probably the most important thing that I could say is the importance of consistency and predictability. In some ways it's difficult to speak in generalities about supporting kids with emotional needs because there's so much variability. But one very common thing, whether we're talking about a child who's depressed, traumatized, anxious, has OCD, has bipolar, whatever the case may be, is that oftentimes this is the kid who needs to have the classroom schedule printed out at the beginning of the day and given to them and previewed with them, and departures from routine previewed. Oftentimes needs new academic content to be previewed because they may have a difficult time organizing it as they encounter it. So they may need help scaffolding it, laying it out ahead of time. These are not the kids who do well with unexpected change. These are not the kids who do well with rapid change. They're not kids who do well when you give them a whole bunch of new information and ask them to sort it out. So in terms of accommodations, instructional accommodations, behavioral accommodations, that's probably the one sort of big picture common thing that we could say that would cut across settings. Another point that I would make just about these kids is that probably the worst thing you can do for a child with an anxiety disorder or a mood disorder in school is allow them to have a meltdown in front of the other kids. Having a child have an anxiety attack, freeze up, start crying, whatever the case may be, in front of other kids is a hugely traumatic experience for that child. And for one thing, kids will put tremendous emotional resources into not allowing that to happen. We'll have kids who are sitting in class, who are on the brink, who are putting everything that they have into holding it together and have nothing left for learning. And on the other hand, when a child does sort of go over that threshold and have that sort of an episode, it's tremendously difficult to get them back into the social mix. And honestly, for good reason. Kids can be mean. Kids get teased. Kids get labeled. You're the kid who cried in the 3rd grade, whatever the case may be. It's really important to provide these kids with a safe space, to provide them with a space, with a person where they can go when they're feeling overwhelmed so that they can have privacy, so that they can deal with what they need to deal with and then go back to class. This may be the nurse in the nurse's office. Okay, this may be an adjustment counselor. I've seen this be the secretary in the main office. Okay, I mean, it doesn't have to be a licensed mental health professional. But there needs to be some sort of a pre-identified person in space that is safe for this person, for them to have privacy and for them to be able to decompress. Beyond that, direct service, apart from, obviously, counseling in school, we think about things like speech and language intervention for these kids that I'm talking about with speech language deficits. Literacy support, people who have difficulties with construction and comprehension of narrative. How does that come out? Reading comprehension. What's the main idea of the story? Why did the character do what he did? Very difficult for these kids to reason through that. So literacy supports, language-based learning techniques, multisensory teaching. We've talked about working memory capacity. How do we present information? Is this child overwhelmed by the pace of instruction or by the volume of the information that we're giving to them? Do they need more of a language-based learning environment where we are teaching in a multimodal way, giving information in smaller bits and at a slower pace? And development of strategies for self-regulation. How do we teach these kids how to identify when they're going to melt down, when they're upset, when they're angry, and teach them something adaptive to do about it? Therapeutic environments. A minority of these kids, a small proportion of these kids, are going to have severe enough emotional symptoms where they will need to transition to a therapeutic learning environment. Okay, this is a setting where we're taking them out of the mainstream for at least a part of the day, not necessarily for the whole day, where they're going to participate in instruction in a small group setting with therapeutic support that is integrated into the milieu, and where there's going to be a much higher level of flexibility than you're going to be able to find in the mainstream setting. It's obviously not the first thing that we want to do with kids, and not something we want to do with any kid. But for a certain proportion of kids, it is going to be a necessary intervention at some point. And then finally, promotion of competencies. I think that when we're talking about these kids, we can really digging into all the things that are wrong and all of the deficits. The social skills problems, the learning problems, the language problems, the self-regulation issues. And yes, it's important to address those things. It's important to give them the therapy and the academic support and everything else that they need. But oftentimes what these kids need more than anything else is a way to feel competent and a way to feel strong and a way to feel smart. And especially if we're talking about kids with trauma, the home and the community may not be places where that is possible. And so one really important role that school can oftentimes play is to identify that. Is a kid knowledgeable in a certain area? Is a kid talented in a certain area? Music, sport, whatever the case may be. And can we really pull that out and build on that and publicize that and give a child leadership in that area and really promote a child's sense of competence and sense of strength in addition to addressing their deficits and their vulnerabilities? Okay, so I think I'm on schedule considering that we started 15 minutes late. So I am happy to take any questions from anyone. Yeah.
Let's say a child that's on the spectrum. Would that child be considered going through trauma because of his or her disability?
Would it,
Not because of the home environment necessarily, but they're higher functioning and they know they're different. Would that be considered a trauma to them?
yeah. So the question is for a high functioning child on the spectrum, could the experience of having the spectrum disorder be traumatic? I think that if we sort of define trauma broadly, then yes, certainly it could. I mean, I think that if we define trauma in a very narrow way, in the way that we typically think of as producing sort of textbook PTSD, we're typically thinking about traumas that are sort of where the individual feels physically threatened or feels like somebody else in front of them is physically threatened, somebody who's physically attacked, who's in an accident, and so forth. But if we think about trauma sort of more broadly, absolutely. I mean, I think that I've seen many kids, especially adolescents, who are high functioning on the spectrum where the experience of feeling different and sometimes feeling rejected is an ongoing trauma for them in the sense that it sort of is an ongoing threat to their sense of personal integrity and safety and wholeness. And so I think in that sense, absolutely. Yeah.
during that time that that's happening, the younger sibling will be like being in the same environment, even if the parents are protective and just help,
Yeah, that's a great question. And let me repeat the question actually. So the question is, in the situation of a child with more severe autism who's showing a high level of self-injurious behaviors, could a sibling be traumatized by being exposed to those behaviors? The answer is absolutely. Yeah, there's no question about that. Anybody who has seen an autistic child with severe self-injurious behaviors knows how incredibly traumatic that. I mean, that's traumatic for me to witness. I mean, that's a very difficult, scary thing to witness. And for a sibling, or a parent for that matter, to see it absolutely crosses the threshold into what could really be a classic trauma and could produce post-traumatic symptoms. Absolutely. Yeah. Yeah.
Do you think that behavior plans are beneficial or helpful to children that have escape avoidance and anxiety around schoolwork?
Okay, so the question is, are behavior plans helpful to kids who have escape avoidance or anxiety around schoolwork? I think rarely, I guess would sort of be my answer. I mean, I think that, what I would say is that it depends on sort of what you mean by a behavior plan. I think that a positive behavior plan that really emphasizes positive reinforcement for engagement in schoolwork can be beneficial. But what I would say about that is that if what we're trying to do is to incentivize a child into doing something that they're not able to do, or that's very, very hard for them, it's likely going to backfire and blow up in our face. You can offer me $10,000 to flap my arms and fly, and I'm just going to get frustrated because I can't do it. If we have a child who is dyslexic and is showing anxiety and avoidance around schoolwork, incentivization is not the answer. I mean, it may be part of the answer, but it's only going to work if it's coupled with actually teaching them how to read. And if it's the only answer, it's just going to be frustrating. And anything that is punishing, a child who loses recess for not being able to do their work, or who loses points for not doing the work, is definitely not going to work out well. Yeah. Yeah.
I'm building on that. What about a child who's depressed? So say you've got a child who's depressed who's avoiding all schoolwork.
Yeah.
It's either fear, flight, or freeze. I don't know which one it is, but totally avoiding it. And all the teachers keep saying, you just won't do it.
Yeah. Yeah. Well, right. So the question is, what about a child who's depressed, who's avoidant and not doing work? I mean, I think that it's so hard with depression because, it is an invisible disability. And I think that, you would look at a child who's depressed and you say, well, you can do it, you're just not doing it, you're just not showing the initiative, you're just not showing the energy, you're just not showing the effort to do it. Yeah, that's the depression. I mean, depression is largely a disorder of volition. When you are depressed, you lose the ability to initiate. You lose the ability to sustain effort and energy. I mean, anybody who's ever had depression sort of knows what that's like. And so, yeah, that's the point. But the point is that it's not that the person is opting out. It's not that the kid is sort of saying, school kind of seems kind of stupid, I'd rather do something else. It's that the child, truly from a biological point of view, cannot hit the accelerator and get going. And I think that's a really hard thing to get across. And I think it's especially hard to get across because you'll sometimes see those kids with, if there is an area that is still pleasurable for them, which hopefully there is something, you will still see them engaging with that. And so you'll say, well, when it's like Little League, like you get out on the field and like playing, you go to practice and stuff, so like what's the deal with the math homework? So that's a little bit of a long-winded response, but I think part of your question was also about the use of behavior plans. I think, again, with kids with behavior plans, with kids with depression, you can use them. Typically, you have to really, really emphasize the positive reinforcement, and you have to have what you think of as very dense reinforcement. You have to really reinforce very incremental steps. If I'm a depressed kid, you can't say to me, yeah, you get your reward after you do your homework for like half an hour. Like, forget it. Like half an hour, like that's like crossing the Sahara. Like it doesn't matter what you offer me. Like I can't do it. Oftentimes you really have to break it down.
you get a point for like sitting down at the table and trying for 5 minutes. You get another for another 5 minutes. You better really, really make it dense and frequent.
What about in school intervention?
In terms of a behavior plan, or
In terms of, yeah.
I mean, you can use.
Forward with it.
Yeah, I mean, you can use a plan like that. You can use a plan like that in school. I think it's obviously challenging to sort of, unless you have paraprofessional support, it's challenging for a teacher to be able to sort of implement that type of a behavior plan in the classroom. But yeah, I mean, I think that probably the most important thing is educating a teacher about the nature of the depression, how it presents, how it's not somebody who's choosing not to do work, choosing to be oppositional, but it's somebody who's struggling with a clinical condition, and that. And trying to sort of frame it not around sort of discipline for not doing work, but around the positive reinforcement for a child's efforts to mobilize their resources.
So you modify the curriculum?
Yeah, absolutely. I mean, I think that oftentimes with these kids, you sort of say, look, for this kid to do the 20-item math worksheet requires twice as much energy as the other kids, and so this kid's just going to do the odd-numbered items. And I think that's a very fair intervention for these kids. It's very logical. Yeah. Yeah. Yeah, the question is who's qualified to make these diagnoses.
Have you ever run into, have you run into a situation where the school, where there's school personnel that are diagnosing anxiety disorder, for example?
Yeah.
Talking about the difference, not necessarily the legal category,
Right.
but the DSM category as a basis for the legal category.
Right. So the question is, do we see school personnel making these diagnoses, and who's licensed to make these diagnoses? So the answer is that DSM diagnoses can be offered by a licensed physician, which would include a pediatrician, but would also include a child and adolescent psychiatrist. They can be offered by a psychologist, but it needs to be a licensed psychologist health provider, which is a special category of psychologist under state law. That does not include school psychologists. So typically a school psychologist or a school adjustment counselor would not be licensed to make a mental health diagnosis like this. Does it happen? Yeah. In the same way that, theoretically a school psychologist isn't licensed to diagnose ADHD, but you'll read in school psych reports all the time, this child has symptoms that are highly consistent with ADHD, and I recommend you talk to somebody about it. So I mean, you can say, yes, a school psychologist might give somebody the BASC, a questionnaire, and say, well, the anxiety indices are at the 99th percentile, so I'm very concerned about anxiety, and you're basically all but diagnosing it. But as a legal issue, it needs to be a licensed physician, a licensed psychologist, health provider, a licensed clinical social worker, a licensed mental health counselor, LMHC, a nurse practitioner. I'm probably going to get angry emails from somebody. Yeah, I'm leaving. I know. Okay, thank you. See, I didn't even have to wait for the email. I got a response right away. So would all adjustment counselors have an LMHC degree? Is that true? Are you an adjustment counselor? All right. So for the webcast, I stand corrected. All adjustment counselors have. Thank you. I actually didn't know that. All adjustment counselors have a LCSW or a LMHC, so they can diagnose. But a school psychologist would not. Okay. Yes. Yes.
So I've run into a situation where there's a school psychologist who has psyche.
That is different. That is different.
Yep. Is that person allowed to make diagnoses?
Well, okay. So the question, we're getting into dense. For people who aren't here, we're getting into dense legal territory. First of all, I apologize to all adjustment counselors that I've offended. The question is, if a school psychologist is also a licensed psychologist health provider, which you do see, I could go get a job in a public school. I'm a licensed psychologist health provider, but I could go do that. Is that person then licensed to make that diagnosis in that setting? I have no idea. That I don't know. That person is licensed to make that diagnosis, yes. Can they do it in their role as a school psychologist wearing that hat? I don't know. Yeah.
Massachusetts, school psychologists are indeed allowed to make diagnoses for educational purposes
Yes.
that are emotional disturbance, ADHD, and I also believe learning disability. But in certain districts, they will not allow them to make diagnoses that are ADHD or
Okay, so it's district by district, is what you're saying.
technically speaking, they are.
But under the law, they can't. And there's probably also, I mean, there's also probably a difference here between an IDEA classification and a DSM diagnosis. I mean, there's a difference between saying that under IDEA somebody has an emotional impairment and saying that somebody has a DSM diagnosis of major depression. Or so, I mean, that's also an issue as well, I would guess. Their lawyers suggest they don't make those diagnoses. Okay.
I'm a lawyer, and I would be just furious if I saw that happen when I was representing, a child in that situation.
Okay.
I just think it would be inappropriate. There's an ethical problem with people who are working for a school district making diagnoses that are usually not making diagnoses. So
Yeah.
well, they have a right to report what they see
Yeah.
in their realm, but I think they might be stepping over an ethical realm.
Yeah, I mean, it's right. It's it's really hard. I mean, I think that but you could also argue the other side of it, right? I mean, you can also say that, I mean, there's been obviously tremendous discussion about mental health resources in school, given some of the school violence that we've seen. And we've sort of talked, as a society, we sort of have a tremendous interest in having people in schools who are knowledgeable about mental health, can intervene around mental health. And so we sort of don't necessarily, on the other hand, want to turn around and say to adjustment counselors and school psychologists and people, no, don't do this, don't do that, we're going to sort of tie one hand behind your back. So it's hard. I mean, there's sort of that other side of the coin as well. Yep. Yep. There's issues of informed consent and confidentiality. Absolutely. Absolutely. Yeah. Yeah.
Is that true for all children? That there must be something neurologically wrong with
Okay, so the question is about executive functioning in the frontal lobe, and do all kids with executive functioning problems have frontal lobe disorders? The answer is no. We think that the development of executive functioning skills is closely tied to the maturation of the frontal lobes of the brain. However, there's not a one-to-one correspondence. We see people who have frontal lobe syndromes who don't have executive functioning problems. We also, on the other hand, see people with executive functioning problems for reasons that are not necessarily associated with frontal lobe dysfunction. Other parts of the brain are involved in executive functioning. And also, as I sort of talked about earlier, we can think about kids who are sort of growing up in a very chaotic environment who don't really learn organized thinking and planning skills. And so we'd say that they have executive functioning impairment or executive functioning deficits, but it's really not so much that they have like a neurological problem. Yeah. Yeah, the IDEA has different disability categories, right?
So a child has been evaluated, and it's determined that the child's abilities are average across all the domains within the child. If the achievement testing psychologically, but in the classroom, you see the child cannot transition from math to reading circle, cannot find a paper that is supposed to have the disorganized child that cannot read from subject to
Yeah.
the child that's
Yeah.
and so we definitely identify that child as having been executive functioning problem, and we come up with ways to accommodate the problem. But the child never qualifies to be eligible for special
Right.
So, I guess the question is, like, how do you know when it's neurological? How do you know when it's not? Would other things appear on that psychological testing indicate that it could be neurological?
Yes, I'm just going to repeat. I'm going to repeat that in abbreviated form for the web audience. Okay. The question is, for executive functioning problems, how do you know when it's environmental versus neurological? I think it's sort of the yeah.
I mean, even at home, this child
Right. A child who has problems with
can't pick up his phone like it tells him.
yeah.
Yeah.
Yeah, so I mean, you're sort of asking two questions. I mean, one is around IEP, is around special education eligibility, that there's not a distinct category for executive dysfunction, which is true. And so there are plenty of kids who have significant problems in school with executive functioning who have a hard time qualifying and being eligible unless the executive dysfunction is yoked to another diagnosis like ADHD or a learning disability or whatever. So it's not a freestanding diagnosis that in and of itself would make you eligible. And that is true, and that's a problem. And that's a problem that's built into the law. The second question that you ask is sort of how do you determine the origin of the executive functioning problems? You know, part of it is around taking a good history in terms of understanding what kind of an environment the child has grown up in and been exposed to. You can also do, neuropsychological testing of executive functioning. Part of the advantage of that is that it can help you to tease out some of the emotional factors. So if I find that a child has a hard time with flexible thinking, even on a test in my office with absolutely no emotional investment in it, with, in a completely emotionally neutral, structured setting, that probably gives me a clue that this is more of a neurologically based problem. And, as opposed to a child who's showing a lack of flexibility with more emotionally loaded topics, like I really wanted to have pizza for dinner and I was expecting to, and now you're saying that I can't. So if we can sort of in the office sort of strip away the emotional layers and find that on a very, very basic level this child cannot shift gears between tasks, that sort of gives you a pretty good clue about the neurological origin of it.
It's associated with the question. If all, she says all those, are they index scores? If all the index scores are average, and then you see issues with self-test scores,
Yeah.
would that indicate, like processing, would that indicate some issues with executive function?
You're talking about like on IQ testing, for example?
Yeah.
So the question is whether variability in index scores on IQ testing can indicate executive functioning problems. The answer is sometimes, but it can indicate a lot of other things too. So.
But that could make them eligible for.
Not necessarily. I mean, it can, can variability on the IQ test make you eligible? I mean, look, I mean, what I'll usually say about eligibility, which is something that comes up a lot in the kids that I work with, is that there needs to be a diagnosis and there needs to be, it needs to undermine effective progress. There need to be those two pieces. I can go into school with an arrow through my head if I'm a kid, and people can agree that I have a real neurological problem, but, that does not in and of itself render me eligible if it's not undermining my ability to access the curriculum and make effective progress. So, there's one issue in terms of fitting with the disability category and having a diagnosis, and there's another in terms of being able to document that it's undermining your ability to progress. Yeah.
I have a question that someone related to answer.
Okay.
And what they're asking, and this could be a question for the future, but with all, this is what they said, with all the research on structural brain differences, what types of scans should be done to confirm a diagnosis done via a neuropsychological evaluation?
So the question is, what kinds of brain scans should be done to confirm a diagnosis in a neuropsychological evaluation? We don't routinely follow up neuropsychological evaluations with brain scans. There are two different kinds of brain scans, structural and functional. A structural just takes a picture of a brain, like an X-ray would take a picture of a bone. A functional actually shows you the brain working, shows you what parts of the brain are working harder than others in terms of things like oxygen use and glucose metabolism. And generally, you don't follow up a neuropsych evaluation with a scan unless the neuropsychological evaluation suggests that there may be an underlying neurological disorder. So rarely you might see a neuropsychological pattern that will raise a concern about a brain tumor or about epilepsy. and then obviously you would follow up with an MRI or an EEG. It's also the case that when a child is first diagnosed with an intellectual impairment, we will routinely do genetic testing. By we, I mean the pediatrician will generally do genetic testing to rule out some sort of an identifiable underlying genetic cause. And some pediatricians will do a brain scan at that point to make sure that there's nothing on the scan. Sure. So, do you want me, you cut me off when you want to cut me off. I don't know if I'm hitting my...
Oh, you know what, as long as people are willing to stay.
Okay, great.
We have all the time in the world
Okay.
for the webinar. We still have 42 people listening.
Okay. And they all have questions. Okay, yes.
I've seen people try to do the anxiety disorder and put it under the health,
Yeah.
health impairment. And there's a lot of, I think NAMI has, and I'm not saying that NAMI has done this, but I've heard that NAMI is pushing sort of doing that, putting it instead of under the emotional disturbance impairment into the other health impairment.
Do you think that so the comment is that NAMI, the National Alliance for the Mentally Ill, is promoting the idea that something like an anxiety disorder should be coded under, or you've heard that it might be coded under other health impairment rather than emotional disturbance. I haven't heard that. Do you think that that's because they're trying to sort of make the point that mental illnesses are physical illnesses? Is that sort of the point? It's a brain disorder. Yeah. I mean, look. I mean, I think that. I mean, anything mental is physical, right? I mean, anything mental is happening in our brain. You know, me talking right now, you listening to me, what we see, I mean, everything happens in our neurology. So, I mean, there is, you know, it's a false dualism between mental and physical. So, you know, at some level, sort of, you know, creating a discrepancy or a difference between health impairment and emotional impairment is kind of a false dichotomy. So I sort of understand the theoretical point that they're making. I think in general, if we're talking about developing a special education plan, it generally doesn't make a huge difference in terms of services and accommodations. I mean, I think whether you check off the one box or the other, it's not like if we check off other health rather than emotional, we're no longer eligible to see the adjustment counselor, or we're no longer, you know, whatever. I mean,
Well, I think it's become a stigma.
Right,
Kids,
right.
having that stigma
Yeah.
following them around.
Yeah, no, it's trying to break down the stigma, and it's trying to sort of break down the wall between mental health and physical health, which makes sense. Yeah.
I was just considering they do that with Tourette's as well. It's a neurological.
Yeah.
Make it fall under other health.
Right, the Tourette's would go under other health,
Yeah.
which makes a lot of sense. Because Tourette's really, I mean, everything's neurological, but Tourette's is like really, really neurological. You know what I'm saying? It's not. There's not a lot. It's getting late. I'm not making a lot of sense, but you know what I'm saying. I'm not. The question. Sorry, I've got to remember to repeat these things. So the question is, are we seeing a trend in terms of Tourette's and ADHD being put under other health rather than neurological? I'm not. Are you? Do you see that? Or the opposite? I usually see ADHD put under other health.
It's listed under other.
Yeah, I see. Yeah.
I know that some directors, I know a couple directors of special ed are thinking that it should be under neurological. I'd like to see whatever.
Yeah, I mean, again, I mean, sort of getting into like what's neurological, what's emotional, what's health is sort of like, you know, sort of to me is kind of how do you define that, right? I mean, it's all health. You know, if you have epilepsy, if you have Tourette syndrome, you have a health problem. It's a neurological problem. You know, just like if you have Crohn's disease, you have it's a GI problem. It's a health problem. It's a type of health problem. And with the emotional piece, again, I mean, you know, is depression a biological disorder? Of course. So is bipolar. So is anxiety. You know, so is OCD. All of these things are happening in the brain. You know, where else would they be happening? So yes, I mean, we can sort of go down the rabbit hole in terms of, you know, these classification issues. And I'm not saying that it's not important. I'm not trying to minimize it. But, you know, my understanding is that once you meet eligibility criteria, regardless of which one of those three boxes you check off, it doesn't influence what services and accommodations you're eligible for. You're raising your eyebrow that I might not be right about that though. So is that a longer story? That's a longer story. Okay.
And one other question
Yeah.
for the web audience. They wanted you to make a comment about placing behaviorally challenged kids with other behaviorally challenged kids. And is that somehow counter, I would say intuitive, but is it counter-recommended?
Yeah. So the question is about placing behaviorally challenging kids with other behaviorally challenging kids, and is that contraindicated or counter? Again, yeah. I mean, it's not what you want to do. I mean, if we're trying to promote different behavior, different ways of coping, different social skills, then obviously you want to try to place a child with other kids who are modeling those coping resources and those social skills. That's absolutely the case, and I think that's that's part of why the law is written to mandate the least restrictive environment. That we try to place a child in the least restrictive environment, and we try to keep these kids in inclusionary settings as much as possible. So I think that that's absolutely the case. Now, on the other hand, I mentioned therapeutic environments before. We have therapeutic environments in public schools. We have private schools that are therapeutic, collaboratives, and so forth. And is there a place for that? Absolutely. It's a cost-benefit analysis. When you take a child from an inclusionary setting and you put them in a therapeutic setting, yes, there is a cost to that in terms of losing the exposure to typically developing kids. In some kids, there's a benefit to it that outweighs the cost in terms oftentimes of that child's safety, in terms of the safety of the other kids and the staff around that child, and in terms of the ability to give interventions at a level of intensity and consistency that you couldn't do in a mainstream classroom. So it's a cost benefit.
Well, I think that the web people are pretty much done, and we are losing the audience.